Okay, so this is a 58 years old man who presented with apprehension for one day. So what do you think is happening in the ECG? So there are obviously some changes which doesn't look to be normal. And with this brief history, so any thoughts what might be uh, positive findings in this gentleman? So ECG might not be difficult all the time. So it's not mandatory that every ECG is difficult and you have to see a lot of things. Some things are very obvious, but they will like to test you with some other associated features of that ECG. So they might not ask you the diagnosis, but they might give you some associated features that might be asked. So anybody who would like to comment on this ECG? So we can see that there are some issues with the STs. There's no doubt about it. So we can see that, look at the STs over here. So V1, V2, V3, V4, V5, and a bit of V6, but not that much. And now look at lead 1 and lead AVL. So what are the types of these STs? So what do you call these STs? So what are the differentials of ST elevation? So I think everybody agrees that this is an ST elevation. So there's no doubt about it. They are very obvious, clear ST elevations, and they are so huge. They are probably more than 6 or 7 millivolts. So they are huge STs. And with this history of 58 years old and who is apprehensive for one day, what comes into your mind? So this looks that this is more of a global involvement. You can see anterior chest leads are involved, the lateral leads are involved. So sometimes you can confuse this with pericarditis. Yes. So look at the ST's elevation. It is more of a concave. Okay, you're more commonly seeing that convex, but the studies have shown that this is not always mandatory that every concave upward elevation is a pericarditis. So this is not a pericarditis, because for a pericarditis, it should be a complete generalized involvement. But here you can see the inferior leads. So these are ST depressions over here in 2, 3, and AVF. So the pericarditis will not give this picture. So don't confuse the type of elevation with the MI, is it present or not. So still these types of elevations, although they are not very typical, but definitely when you elaborate this and you see the patient as well, but that is for the clinical practice. But in the exams, so you do not have the patient with you and they give you a very brief history because they don't want to give you the hints. So they want you to pick up. So this is based on your experience. How many cases have you seen? So this is not that a difficult scenario. So you shall not waste a lot of time. So this is basically, this was a case of large myocardium infarct. So in this case, the territory of the anterior wall and the lateral wall was involved. This was an extensive kind of myocardial infarction of the anterolateral walls, and there was a reciprocal depression in the inferior leads. So it was pretty straightforward. But this was just to show you that if the multiple leads are involved, then definitely this still can be an MI. And you always have to look every lead and always look for the signs of pericarditis. So you have to rule out these two changes, especially in the acute settings. So let's move forward. So I marked you with this arrows, the findings which were present. So this was an extensive anterolateral wall MI. So it was a pretty easy one now. So the next ones will be definitely a bit tricky. So now I've not given you the history because obviously there are some findings and these findings should not be missed. I think by one who's dealing with the cardiac patients who have done the training in the medicine and even cardiology. So this ECG should not be missed. This ECG requires a definite diagnosis. So when they give you an ECG with an easy diagnosis, they expect you to write all the associated findings or association with that pathology. So anybody who would like to comment on this ECG? So I have purposefully not this.
Yes, sir. This is the ECG showing ST elevation 2, 3 AVF, and there's the V1 ST elevation and reciprocal changes in lead 1 and AVF, and V2 ST depression. So this is the acute inferior wall MI, most probably with the RV infarctions, and along with 2 to 1 heavy blast.
Okay, great. So we'll not comment into AV block. So for that, we might have to look up for a little all other things, but good, this is very right. So as you can see that the ECG is very obvious. Again, you are seeing an ST elevation that are so used. Now look at these types of elevation. Look at the previous which I showed you, and now look at this. So although over here you can see that which you are used to seeing in your practice or in your training, but now this is no doubt inferior wall MI. But you should be knowing the associations of an inferior wall MI. So what are the associations? So two things you have to look for that. One is the posterior wall MI, and the other is the right ventricular infarct, because definitely the management might change a bit, not a bit, quite a lot with RV infarct. So everyone agrees this is a right ventricular infarct, or anybody who says that this can be a posterior wall MI along with inferior wall. So everyone agrees with the right ventricular infarct. So there's no doubt about inferior wall MI, and he's having AV blocks as well. Okay, so but what about the anterior chest leads? So what do you think? This is an RV. I have given you. So let's move forward. I think nobody would like to comment further. So
yes, sir. To diagnose RV infarction, as we can see, sir, in V1 there is ST elevation and V2 ST depression. When we have V1 ST elevation and ST elevation more in lead 3, so it directs towards the RV.
So now you can see, look at, I've marked the arrows for your help. So now you can see there is an ST elevation in V1. Okay, there's no doubt, very clear ST elevation. Now there is ST depression in V2. There is an R wave in V2, but for a posterior wall, considering the leads are placed properly, which definitely they should be. So V2 in V2, the R will be more than the S, but this is not the case over here. So although ST depressions can be seen in posterior, but why there is ST elevation in V1? So this is not a feature of a posterior wall MI, and the R wave should be more than S wave. R wave should not be less than S wave in posterior, but here you can see the S wave is more deeper than the R wave. Okay, so there are ST depressions in lead 1 of more than 2 mm. There is ST. This is one again feature which I think you should remember when you are diagnosing RV infarct, that ST elevation in limb lead 3, it should be more than ST elevation in limb lead 2. I think you can appreciate that over here, right? I think there's no need to measure it. Apparently, it looks definitely more than lead 3 is showing more elevations than lead 2. Yes?
Yes.
Okay, so this is very classical picture, very, very classical picture. So I've seen this patient, so it was a very good ECG for academic purposes. So now these are the findings which you should be writing for full marks. So apart from that elevations, you have to write all these findings. Okay, so again, see them carefully. So these 5 findings, although they are very obvious, but don't miss them, because definitely this might cut your marks. He might be expecting, because he might ask some other questions which might be linked to the next point or question regarding management. So the thing is that always in the case of MI, pick up everything. I have not commented on AV blocks because that will be again a very different kind of topic. So we know that inferior MI is linked to AV blocks. You can write AV blocks. You need to measure them, but I have not measured them over here because they are very obvious, and obviously we expect. So what do you think the lesion might be? So they might ask you a question.
Dr. Hassan,
Yes.
there's an ST elevation in V5 and V6 as well. So how would you explain that? Could it be because of the super dominant RCA, or
Yes.
and shall we write inferolateral in this case?
Yes, yes, very right. Because sometimes the RCA is dominant. It's so huge, it splices the left uh, part of the ventricle, lateral wall of the ventricle as well. So that's why you're seeing so many changes. So you can see the RV branch is in fact affected. There is this is more of a proximal RCA lesion. Okay, and the V5, V6, yes, because sometimes RCA is so huge that it splices the lateral wall as well. So yes, you can write that as well. But the aim was, I wanted you to pick the RV infarct in this case. Obviously, everyone knows what an inferior wall MI looks like, but the aim is don't miss a right ventricular infarct. So you have to remember these things. These are the features of the RV infarct. So we have seen majority of these features. So there should be an ST elevation in V1. We have seen that. ST elevation in V1 and ST depression in V2, which we have seen that in this patient. It is highly specific finding for RV infarction. Okay, so highly specific finding for RV infarction. If you not see that and you see an isoelectric ST segment in V1, this is another scenario. If you don't see an ST elevation, even an isoelectric ST segment in V1 with marked ST depression in V2, again, think of RV infarct. ST elevation in lead 3 more than 2, and reciprocal ST depressions. So this is all in the literature. You can go and read through that. But in this patient, majority of the features were fulfilled, as you can see that. So ST segment elevation, if it is 1 millimeter or more, now this is considered highly sensitive and reliable marker with sensitivity reaching around 98. Some studies have shown 100%, but on an average, it is around 95 to 100. So it's so huge sensitivity for this. So you have to remember these findings. Okay. So always whenever you see an inferior wall infarct, try to diagnose an RV infarct and remember which is a highly sensitive and which is a highly specific. Okay. So I've marked them, underlined them for you. So one important thing, this is just for your clinical practice. The ST segment elevation in the right precordial leads, the V1, the V2, it is transient. So it's not always the case that the patient might be having an RV infarct, but since these changes depends upon the patient presentation. So in 50% of the patient, if they have passed more than 12 hours after the first onset of chest pain, these changes might go away. So this is one interesting finding. So you can pick that on the echo, obviously, because RV, when it will infarct, it will show some signs on the echo as well. But this is one important point just for your clinical practice, that these changes are transient. So anybody who can comment why these are transient? Any guesses or anyone who has read this before this point? So don't worry, I have another slide just to give you the reasons for that. But I just want your minds to just work and think what are the possibilities. I'm not sure that these questions might have been discussed with you, but obviously there's a lot of literature now on MI and a lot of studies being done. So this is one interesting thing. Okay, so these are transient. So these are some plausible suggestions for these RV infarct, why they are transient. So as you can see that pulmonary circulation is approximately around 1/10 the length of systemic circulation. The pressures, because the left system has a higher pressure, the pulmonary circulation has a lower pressure. So the gradient is not that high. So sometimes, cause as you can see, there's a gradient for the blood to flow. So these are the kind of you can say these are not proven one, but these are suggestions that have been given after the studies have taken place and lots of research was done. So they have suggested few findings and few reasons. So one is the gradient, because this is not a high pressure system, so field gradient around 5 millimeters difference is good enough to supply the blood towards the pulmonary circuit. Okay, the second point is, unlike diastolic flow in the left ventricle, the RV wall is thin. And in the case of left ventricle, the coronaries are profuse in the diastole. But in the case of thin wall RV, this is a biphasic. It's most in the both in the systolic as well as diastolic. Okay, so this is another point. So because of all these features. Third point is they have rich collaterals. The rich collaterals from the left anterior descending artery in addition to right coronary artery. So the collaterals save them. So they kind of perfuse from these collaterals. Okay. So these are the three changes that have been mentioned in the studies and literature, which might be the reasons for their transient changes. Okay. So just remember that it's not always the case you see ECG changes all the time. So these are transient. So this is just to apprise you of where the leads are placed. This is again important because you have to clearly see the right-sided, although I've not shown you the right-sided ECG because this was not done in this case, but the V3 and V4 are the right leads. Usually you place it on the left, but whenever you see want to identify the infarct, so those are the changes which you see on the left side. The leads are placed normally, but sometimes you also place them on the right side. So the leads that are important is V3 and V4. So this is just the mirror image of how to place them normally. So just remember that this is a mirror image of the left-sided leads. So just shift them just opposite of that intercostal spaces. So you can remember from these, you can remember the lead placement for the left side. Obviously, this is not difficult for you to go for the right side. So this is just the mirror of that. Okay, I hope it's clear till far. Okay, so this was the case of inferior wall MI with RV infarct. Okay, let's move forward. So things will be getting a bit difficult now. I think this just was to warm you up. Okay, so anybody, I've not given the history because history will not definitely help you a lot in the case of arrhythmias. So you just have to use your clinical knowledge and expertise for that. So just have a good look on these ECGs. I'll give you some few seconds. Okay, and then I will request somebody to please comment this. This is again a very interesting thing. So just take a moment and then we'll discuss this. Okay, so anybody who would like to comment? So it's a tachyarrhythmia, right? So tachyarrhythmia, is it a narrow complex or is it a wide complex tachycardia? What do you think about it? Okay, I'll give you hint. Look at chest lead V1. So this is the questions. I think they will not ask you more than these, more than 3 questions. There's no time, even 2 questions probably. So you have to write that in just few minutes. So you have to be quick in making the diagnosis. Just train your mind because sometimes the questions might help, and sometimes you just have to see the right lead for that. So what do you think? What's happening in the lead V1?
Is it an Ashman's phenomenon?
Okay, so but what's the
This
what's the other thing? So look at the
it looks like
question.
it's a narrow complex where the two P waves are coming intermittently in between the two RS in the V1.
Okay, great, well done.
And some premature beats are there.
Premature, like atrial beats or ventricular beats?
It looks like APC, sir. Atrial beat.
APC. So
Yeah.
yeah, these are APCs, but look at, okay, so I'll give you, now look at this. So what's the, would you think that what's the rate like? So obviously we can see this is P waves. Yes.
Yes.
Over here it's very clear. Look at V2. Look at here. So and this is a tachycardia because there are some pauses, but that's not because of the issues with the ventricles. That is because a functional block is happening. Okay, look at over here. So this is a variable kind of block. So what do you think? What's the rate like of these atrial beats, P waves? It's very fast.
Fast, almost 300.
Yeah. So APCs, so many APCs at the same time is unlikely, no? So this means
Yeah.
there's some techie going on, and sometimes it conducts very well, and sometimes it doesn't conduct very well. It gives some pause. So you can see what the question was. What are the findings? So you have to write because the questions are laid out. So the answers are according to that questions. So you have to answer that questions. So the findings is definitely there is some tachycardia. You can write SVT at your level, but SVTs. So there are 3 types of SVTs: AVNRT, AVRT, and atrial tachycardia. But over here, they are giving you some hints. AVRT is definitely ruled out as we have discussed in the previous lecture. So AVRT circuit doesn't fit in over here. So the other possibility is AVNRT and atrial tachycardias. But this looks more of an atrial tachycardia because AVNRT, you don't see such types of AVNRT as a routine. Okay. So for an AVNRT, they will give you a proper one-to-one tachycardia. Now, I hope they should give you, but I think try to give answer that looks more common. So this was an atrial tachycardia. Obviously, you have to write that P waves, okay, and the rate of that P waves, variable conduction blocks, functional blocks. So the question was, you said it rightly, Ashman phenomena, but the other differential will be a PVC, right? The Ashman phenomena is an aberrancy, but the other differential will be a PVC. So somebody can write PVC over here as well. So the one who said Ashman phenomena, can you please tell me more about that? What is Ashman phenomena? You were right. Okay, you were right. This was an Ashman phenomena happening, but why it happens? And can you share your thoughts with us? Okay, Ashman phenomena. I think this I think this is one of the favorite questions for cardiologists. Probably they like such things when there is a kind of confusion between two things. So
it's kind of an interventricular conductional delay that happens because of the changing preceding RR interval, as per my understanding.
okay, that's very good. Okay, so I'll give you now details of what is this. So this was an atrial tachycardia. I think that's pretty clear. You can see huge discrete P waves. Okay, so look at these intervals. It's very obvious. There's no need to measure that. But still I have highlighted it for you. So this is a long, this is a short. So now the conduction system has some properties. So remember that the decrement occurs at the level of AV node. Anything below the AV node, always think as an all or none phenomenon. Either it will conduct, either it will not conduct. The decrement is at the level of AV node. Okay, so below the node, infranodal, there is all or none phenomena. So now what happens is the Ashman phenomena is a physiological because it has nothing to do. It's just what the system is facing at that moment of time. So it's an aberrancy because of this long short cycle. So one beat is going slowly and suddenly the next beat is going pretty fast. So what happens is the conduction system doesn't give away. So a part of conduction system either completely blocks or a part of conduction system blocks. In this case, a bundle branch block was happening. So it was a right bundle. Yes. So look at V1. So it is a right bundle. It can never be a left bundle in this case. More commonly, the right bundle is commonly seen with Ashman phenomena. This is the more common pattern, but really left bundle can also be seen. But in your case, think of a right bundle whenever you see as a Ashman phenomena, when you see a long and short cycle. So you will not be doing anything for this. This is not a PVC. Okay, this was an Ashman phenomena. You will not treat this. You will only treat this atrial tachycardia. So there are criteria. We call it a fish criteria. So he laid some criteria. So let's study that. So it's a long cycle immediately preceding the cycle terminated by an aberrant QRS complex. Okay, so now I'll show you this picture over here, what was happening. So now let's apply these criteria over. So long cycle, okay, and this is a long cycle and this is a short cycle. So this criteria is met, okay. Right bundle branch from aberrancy, we have seen that it was a right bundle. Irregular coupling of aberrant QRS complexes. Now this is, I think at your level, you should remember these two things. But for those who want to be more purist and who need to understand everything, so sometimes this is very clear over here, but the life is not so easy. So sometimes there are some runs going on, and then you are very confused that is it a VT run going on or is it an aberrancy going on? So there will be some ECGs you will be seeing. In this case of tachycardia, suddenly the QRS gets plotted for a few beats, and now you're confused with PVCs versus aberrancy. Okay, so for that, you will be seeing the irregular coupling of aberrant QRS complexes. So what does this mean? This means that this complex and the aberrant complex. So the coupling interval means from here to here. So this is a link. So this will not be a fixed because patient is having, you see this phenomena more commonly in atrial fibrillation, right? Because it's pretty fast and you can easily see that. It can still be seen in atrial tachycardias. As you've seen in this case, this was a real patient. So more commonly, atrial fibrillation will give you because there's a lot of conduction issues because of all these aberrancies and delays and multiple phenomena going on. But mind it, it's not always the AF. We have seen that in this case. So the irregular coupling interval means like if it's an atrial fibrillation or atrial tachycardias, there's a chance that this beat and this beat is, let's suppose, 200 millisecond. The next beat, which show this phenomena, might be having this interval of 240. The next beat will be showing 260, but with the same long short sequence. So this usually doesn't happen with PVCs. Okay, PVCs is more of a fixed, not that variable. I hope you understand my point. So everyone is clear with that point. If you're not clear, you can ask, because this might be quite dodgy point. I hope you understand that point. So the thing is that the coupling interval is from here to here. It can vary a lot in the case of a Ashman, but if it's a PVC, usually it is a fixed. So sometimes the ECG, I will definitely discuss with you if I get that ECG regarding all these. But just for your knowledge, I think just remember that for your exams, these first 2 points. And lack of fully compensatory pause. This means that the cycle length, like if there's cycle length of, this is a 1 cycle length. Okay. So if after this, the pause is not full compensatory, means like 2 times the cycle length of this one. Okay. So this again goes in the favor of aberrancy, because the ventricular beat will mostly give you a pause. So whenever a PVC comes, there will be a pause, a long pause, which you call it a compensatory pause. So just remember, a very long pause, if it's not there, then again, it's more of an aberrancy. So these are the features that will help you in differentiating. There are a lot others as well, but I think just remember 2 to 3 of these. Okay. Otherwise, any long short sequence, just write Ashman. This is most likely the answer. But just for your knowledge, so just remember these points. I think we'll probably the next case. Okay, now this is a next case. It's a very interesting case. So I've shown you a previous ECGs, but now look at this ECG. If you remember that ECG, okay, we'll discuss that. Just have a look at this ECG and then we can discuss what's happening.
So is this a WPW alternance phenomena?
Okay, that's okay, good. So this was pathway. So now you see, I've shown you in the previous lecture, there was a PVCs that were a bigeminal pattern. And if you do not see the P waves before these white beads, then you can give a very wrong diagnosis, definitely with a wrong plan of management. So good, this was a pathway that was intermittent. So at one beat was conducting through the node, the other was conducting through the pathway. So this was not a PVC. This was a pathway, perfectly timed pathway conduction after one beat. So this is a very interesting slide, usually not seen, but I've seen this patient as well. So, okay, just remember your basics. Don't just jump to the diagnosis. Always measure your intervals. Look for everything on the ECG. Okay, I hope everyone agrees with this. So, okay, let me show you the next slide. Okay, now I've marked the arrows showing these white beads with a bit of slurring, and there's a P waves preceding that. Okay, so this was a pathway. And now look what happened. After a few moments, it gone from 2 to 1 to 1 to 1 now. You see? That's all pathway going. So look at this. And this was the same activation. No difference at all. So this was the same pathway that was conducting 2 to 1 after one sinus beat, and now it's conducting purely from the pathway. Okay. It's very these signs were seen after a few moments on repeating the ECG. So this was a pathway. Don't confuse it with the PVCs. So what is the WPW or accessory pathway? So the definition for that is there is a shortened PR interval of less than 120 milliseconds. Okay. There is a slurred QRS upstroke. We call it as a delta wave. I've marked that. There's slurring, you see. There's a prolonged QRS duration. It's not that prolonged, but it's prolonged from the normal, more than 120 milliseconds. It will be not very wide, but it will be a wideish kind of, it will not look narrow, normal, healthy, going through the conduction system. So any, would you say that any participant who can tell me why a delta wave is formed? I hope you have seen this 1,000 times, delta waves. So what makes a delta wave? So this is, I think, becoming a cardiologist, you should be knowing that delta wave. Okay, so this is a pretty common ECGs. You will be seeing that in your practice. So why delta wave is formed? Anybody who can comment on this?
So it's like a pre-excitation of the ventricles because the accessory pathway is closer at that point. So the ventricles are pre-excited, and that's how delta wave is formed.
So the question arises, the conduction to the pathway, is it sleek or it is kind of bizarre? What do you think? Conduction down the node is faster or conduction normally in the normal? So what do you think? Which conducts more quicker than the other, pathway or the node?
The pathway, obviously, because the node head has a detrimental quality to it.
So why this slurring? Because as we have discussed, slurred means a bit of delayed. It should be very fast. Then why the delta wave is seen? So why it is slurred? That is the question.
Because of pre-excitation.
We know that it's a pre-excitation. Anybody else who would like to comment? Can help her out. Because delta wave is a slurring. That's why it's a delay. That's why you're saying a prolonged QRS duration. Otherwise, the QRS duration should be shorter than that. If the pathway is conducting, the node is not conducting. Kindly unmute, please. Who do not want to comment. This kind of. Okay. Just remember now, because this is a very interesting thing. I always ask the trainees, and mostly they found it difficult. Okay, don't worry. So after this, you will be definitely knowing this. So the delta wave is formed. So always remember, you cannot stop the conduction down the node. It's just the predominance of the conduction. Unless you give some ablation or you ablate that area, you give drugs. But the pathway is inserted on the ventricular myocardium. Although the pathway conduction is fast, but the ventricular myocardium conduction is not fast. Okay, the myocardium, because these are muscles, these are not fibers, so they will conduct slowly. So it's a mixture of conduction of both the node and the pathways. So because the pathway conducts very fast than the node, the pathway conducts on the pathway attaches on the myocardium. These are for the typical pathways. So these I'm discussing all about typical accessory pathways. There are some atypical, we'll not go into that, but we'll be discussing typical behavior. So because they are inserted on the ventricular myocardium and it conducts slowly, so that's why you see a bit of slurring. So it's the site of insertion. Okay, so just remember, it's not always that if the pathway is conducting faster, the conduction will be going through the pathway only. It will be definitely going through a node, but that takes over. So that's why it was intermittent conduction. Sometimes it was going through the node only, and sometimes it was going through the node and the pathway, but definitely pathway was taking over majority of the activation. I hope it's clear now. So these are very easy parameters to remember: shortened PR, slurred uptake, and prolonged QRS. Okay. So you can, just for your knowledge, you can just ablate the node, the pathway will still conduct. So you have to avoid obviously the pathway conduction because it's not physiological. So you always ablate the pathways. So what are the high risk features? What are the high risk features of pathways? Just remember these high risk features. They are asked in the exams. So W is very commonly asked in the exit exams. Just remember some features because they might give you an ECG with this kind of intermittent conduction, and they might ask you, is it a high risk pathway or a low risk pathway? Okay, so they might ask you. So first the diagnosis, second whether it's a high risk or a low risk. So what are the high risk features? The high risk features are male gender, early detection of the pathway, patient with pre-excited atrial fibrillation, and any patient who was having syncope because of any arrhythmias like AVRT, any congenital heart disease like Epstein anomaly. Epstein anomaly is that patient in which it is always the pathways should be you should be always be looked for, because hardly there's any patient who is not born without pathways in Epstein. This is, and again, a very important question. So they present with the right bundle. Always look for pathways in case of tachycardia, these patients, and familial. So these are the high risk features. These are the clinical features. So in these patients, you see this. This is a clinical features, but they might ask you the ECG features. So what are the ECG features?
Sperry, shortest pre-excited R2R interval.
Good, great. So I've given you both low risk and high risk. Majority are high risk. So just remember high risk because they will not ask you low risk. Okay. So you have to unfortunately remember the high risk features. So just remember these. So shortest PD is definitely written more in the books. So that's why you remember that. But it's not always the case. You don't see the tachycardia as always with the pathway. So if the pathway doesn't go away at all, it always persists, this is a high risk pathway because there's no conduction going through the, like without the pathways, it's always conducting, always conducting. So one of the indications to ablate pathway in the patient who is totally asymptomatic, this is because it is associated with a sudden cardiac arrest. So just a presence of pathway itself without doing anything can be a source of sudden cardiac arrest. Not that in a very few population, but definitely even one case is, if you can say, one life by ablating pathway. So a persistent pathway that's not going at all. It's still staying all the time. Whenever you see the CG pathway is there. So it's a persistent, it's a high. Multiple pathways. One is left free wall, one is right free wall, one is septal. This is high risk features. If you can reduce an arrhythmia like AVRT, this is again high risk features. The points which are favorite for the cardiologist. So short SPIRI, shortest pre-excited RR, that is less than 250 milliseconds, and accessory pathway refractory periods. You measure them on the EP. Okay, but just remember the names. So accessory pathway refractory period less than 240 milliseconds. So these are all high risk features. So now let me give you a scenario. So let's suppose you find a patient who is having this pathway conduction 1 to 1. Okay. And now, because you do not have, everyone doesn't do EPs and all these, when patient is not having multiple pathways on the ECGs, okay, inducible AVRT, you cannot induce, obviously, in the lab. So what will you do clinically? Because these are done by the electrophysiologist, but as a cardiologist, what would you like to do if you want to see that patient is more towards high risk or low risk? Anyone?
We will do some exercise test
Okay.
just to see the delta wave is persistent during the exercise or it is abolishes or
Okay, so if it abolishes, so you think it's always a low risk if it abolishes? Because you know the because of the sympathetic system acts more on the node, the patient exercises, the conduction through the nodes get better. The pathway conduction will not be completely or predominantly from the pathway. So it still be going to the pathway. But what is that point? So this question was asked. This question was asked. ETT was given. You are right. Do ETT. Obviously, you can do ETT. It's very easy to do that. It's available everywhere. So you are right at do ETT. But the thing is, remember, I've written a term called abrupt and complete loss. Just don't forget this. So if the pathway goes slowly, like slowly, but still looks there's a bit of conduction, but not predominant. And the other scenario is it's abruptly gone. You just start exercise and boom, there is no conduction at all. So it's abrupt and complete. So these pathways are, this means these pathways do not have the tendency to conduct at a faster rate. Obviously, they will not be able to sustain a tachycardia. You get my point? You understand this point?
Yes, sir. Well, I got this point.
So,
but the only question here, sir, at what stage we can say that it should loss on exercise earlier or as the progress?
So the thing is, the conduction, there's conduction properties of the pathway. So now when you are kind of increasing the sinus node activity, okay. So now let's suppose the resting heart rate is 80, and now you've asked the patient to exercise, it goes to 140, okay. Okay, or even you can say 110. So the patient is, the heart rate is now going at 110. So at 80, it was conducting. At 110, it suddenly stopped conducting. So this means that if the patient might develop a tachycardia, he might develop AFib, atrial tachycardia, anything, okay, in the future. So what happens is, this pathway doesn't have the property to conduct faster than 110. So how will it sustain tachycardia? So early, obviously, because if the patient is not able to like exercise too much and pathway goes, and it goes abruptly, not gradually, because gradual means there's still conduction, it has a tendency to conduct. So it should be abrupt, it should be complete, and obviously the rate also matters. The SPIRI comes over here, you see, because the faster the rate, the shorter this R intervals, the more chances the patient might go into VFib because of this faster conduction. Okay, so the reason behind this SPIRI is that when there's so fast conduction, like 250 milliseconds is very fast heart rate. So this means there's a high chance that patient might go into ventricular fibrillation. That is the cause of death. So this might be the first presentation. So that's the purpose of ablating these pathways. Okay, so it's not clear cut that it's a low risk. You never know with the passage of time. There are so many changes going on. So patients are still at high the risk of sudden cardiac death. So but there are some conflicts. We'll not go into that. Just for your purpose exam, just remember these points. Okay, these are more than enough, I think. to pass you in that station. Okay, so it's clear over here. Any questions? All clear?